June, I invited Dr. Raj Makar, and Ramesh was with me in that same program. We do annual cardiovascular symposium, and I asked this question to Raj, that is TAVR for all? And he did the talk, but he made this question mark at the end, the TAVR for all. When Nasser was doing the talk, I made some quick changes so that we don't overlap. So we have come a long way. If you think about this, that we did the initial studies, the partner series of trials, and if you think about the partner 1A, where high-risk patients were randomized, and then partner 1B, where it is inoperable. In the partner 1B, the absolute reduction in mortality was 20%, which means 1 in 5. This is probably one of the most powerful efficacy trial in cardiology. So 20% absolute reduction. But then, if you look at the partner 1A, which is the bottom panel on the left, we were neck and neck with the surgery. So it is a good thing. And then we had partner 2, which we'll talk a little bit in a second. But look at partner 3, which is the low-risk group. Low-risk group, and still we are doing neck and neck with surgery. So what does it mean? Do we do TAVR for everybody? TAVR for all. The questions come, what about if those who have the concomitant need of revascularization? Can we do complete revascularization? What about the bicuspid valve and the aortopathy? All these will come into play. So there is a recent publication in BMJ that with the TAVR, if you look at this, a lot of other issues come in. Coexistent moderate to severe MR, AFib, pre-existing AFib, COPD, CKD, and more importantly is the overall frailty, and the outcome may not be as you wish. And we looked at the data from the Medicare, and we published that those who are transferred or who are already in hospital, and if you do TAVR in them, their odds ratio for bad outcome is really not acceptable. So we try not to do TAVR in inpatients, optimize, assess, and then we try to do it. And there will be a lot of issues why that is the case. But we are just in the stage of learning this. If you recently seen a publication in JACC where it says cardiac injury following the aortic stenosis and the consequences, the LV dysfunction, even the LV diastolic dysfunction, left atrial enlargement large, and then AFib, then pulmonary pressure going high, and then right ventricular dysfunction. All these come into play for determining the outcome. And access is a big issue. There are several accesses. If you look at the partner 2, which is in the left side, overall, in partner 2, which is in the intermediate group, high risk, low risk, and now intermediate risk also, we are neck and neck with surgery. But if you look at the cohort where they got femoral access, the TAVR actually performed better than the surgery. So if that is the case, and knowing all this, let's talk about a patient. 80-year-old, dyspnea on exertion, EF normal, mean gradient 40, aortic valve area is 0.7, and not a significant coronary artery disease, and wedge pressure a little bit high. We need to discuss this with the patient. The big 5 complications: stroke, the bleeding, excess size bleeding, then the requirement of pacemaker, kidney injury, and then paravalvular leak or residual mitral regurg. There are other things that can happen. Valve malposition embolization, I hope it doesn't happen. But if you look at the conversion rate from the TAVR to surgery, is significantly decreasing from the earlier experience. So pre-TAVR assessment, it is like a multimodality imaging. We need to make sure that in addition to the echocardiogram and then cardiac catheterization, we evaluate the access site, we evaluate the aortic root, we evaluate the after implant possibilities, such as prediction whether the apposition will be good or not. Intraprocedural imaging is critical. We can do that with the echo mainly, and then post-procedural assessment. And this is what we do with the pre-TAVR assessment, the aortic root and sizing, and there will be report on your patient, and we have the what you call the TAVR protocol of CTA. You can get the implantation angle, you can get the distance of the aortic, the coronary origin, so that you stay away from the obstructing the coronaries. These are very basics of measurements for the TAVR. Also, it helps in terms of calcium scoring of the whole aortic valve. Very high calcium, where the gradient is not more than 40, as Nasir was mentioning, then calcium scoring may let you think that this is probably severe AS. And then we go for the intervention. So the access sites, it's very critical because you need to look at the calcification, the lumen area, the sheath size. We need to negotiate the sheath, angulation, tortuosity, all these are important. And we do like a micropuncture, fluoroscopy, then do the bifurcation with ultrasound, then micropuncture needle, then take a pictures. And this is like a non-negotiable now, because you cannot compromise the access site. You need to secure the access site. And then we do pre-close, par-close mainly. I don't know any of Ramesh or Dr. Guzman whether you use the mantra device, but that is something also available. So fluoroscopy, ultrasound, the micropuncture needle, we usually 7 French sheath, then we get ready with the 2 pre-close, and then if needed, following the procedure, we tighten the suture, deploy the suture, and if needed, we put an additional angiosyl. So this is one of our patients. So there was calcification, and we thought that it is important that we get the access site and the delivery of the device is smooth. So we actually did a shock wave on the way for the peripheral calcified vessels. And then we got enough lumen. And then we go up with the stiffer wire, and we go with the delivery sheath. So this is good lumen. And then we go with the delivery sheath. And then we usually cross with the Amplas AL1 catheter and stiff wire, or Terumo straight wire. And then we change it with the pigtail and then safari wire, and then we deliver the sheath. We usually keep a pigtail catheter in there, and then we see the implantation angle, make sure that the position is good, and then valve is deployed, and then you can just check the valve, any aortic regurgitation and any mean gradient after. And sometimes we add few more cc to inflate again, or sometimes we need post-inflation. So TAVR, we need to make sure that who may not do well and assess that way. Otherwise, I think TAVR is, the indication is getting wider. And we need to understand the moderate aortic stenosis can be symptomatic, and we need to think about that, particularly those who has the consequences of cardiac injury who may benefit. We need to understand the low flow, low gradient in LV systolic dysfunction. We need to recognize the paradoxical low flow, low gradient, where the LV systolic function may be preserved, but the stroke volume is less. Bicuspid valve is a big challenge. Bicuspid valve with aortopathy, we try not to do it. And then bicuspid valve with aortic regurgitation, probably will not be able to do the TAVR. And then we have the challenges with procedural challenge, the sheath size. We need to talk to the engineers how we can lower down the sheath size, the delivery of the devices, and the durability. You have seen the durability with the initial TAVR, still very, very encouraging. I'll stop there.
Thank you, sir.